Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John.
Morning, John.
Morning, Zara. How are you?
I'm okay. It's bright and early here. We're in the thick of summer finally, so I'm very happy.
We've got plenty of storms going down here in the United States, causing significant issues.
Yeah, I heard about that. Well, global warming.
The speaker coming for us today, who's presented and done a podcast for us earlier on pancreatic cancer, we want to welcome back Professor Phillip, medical oncologist at Wayne State University of Medicine, and Henry Ford will be talking to us today about neuroendocrine cancers, which is an area that Phillip has spent many, many years in specializing and researching. So welcome back, Phillip, to talk to us again, following on from your pancreatic cancer episode. So over to you to introduce yourself.
Well, hi, Zahra. Hi, John. This
Hi.
is a pleasure to be with you again. I'm sorry your weather may not be the best, but we're having a very nice weather here in Detroit today. So you're invited to come if you'd like to have some refreshments and things I can provide. And thank you very much for giving me the opportunity to come back to do a podcast. And this time on neuroendocrine tumors, as you said before, I'm a professor of oncology. Wayne State University School of Medicine, and my practice is currently at Henry Ford Hospital Health System, and I do only gastrointestinal cancers, and I focus on neuroendocrine tumors and pancreatic cancer. So these are areas that I'm quite familiar with in terms of the experience. But having said that, it's really something we continue to learn and add experience as we go along. So there's no way we can complete mastering of the field, especially in neuroendocrine tumors, where it's a kind of a large number of patients we see nowadays who have different varieties of neuroendocrine tumors. So there's no, unlike pancreatic cancer, and I can be more focused on, say, pancreatic cancer. In neuroendocrine tumors, there are a variety of presentations, and the reason is that neuroendocrine tumors can happen in almost any place in the body, and it arises from the neuroendocrine cells. And by and large, they are not very aggressive cancers. But that doesn't mean that some of them aren't, and some can transform into more aggressiveness. The ones I really want to focus on today are the neuroendocrine tumors that arise in the gastrointestinal tract. And here I'm referring to the entire gastrointestinal tract, including the pancreas. These tumors can be different. There are a lot of differences in their ability to grow and metastasize. Yeah, I mean, progression. So, for example, in the stomach, we not infrequently see patients who undergo a, uh, for example, a gastroscopy, endoscopy, and people find some little polyps. They call them neuroendocrine polyps, and these are really not tumors in the sense that they are going to metastasize. So you have this is the far end of the spectrum of a disease that behaves like a benign disease. And sometimes when they see doctors who don't have experience in it, they're told that they have like stomach cancer or an aggressive disease, which they don't. Number one, the prognosis is excellent. Over 95% are cured by just removing the polyps. But also, the thing to keep in mind is that those patients may be subjected to a lot of tests that are unnecessary, not to mention the mental stress because of they're given a kind of a cancer diagnosis.
Just before you go on, can you just maybe speak to the incidence of neuroendocrine tumors?
So neuroendocrine tumors are certainly uncommon. They're not common tumors. However, because most of the patients live long with it, the incidence, which is how many patients are in the community having a neuroendocrine tumor, is much higher.
Okay.
compared to, for example, relatively speaking, compared to other gastrointestinal cancers. Again, the incidence is low, it's very low. However, there are more patients around with it because people, most of them, fortunately, live a long time with it.
Right. So it's not so symptomatic then, perhaps? It's not such a symptomatic cancer, or?
Yeah, it goes unnoticed in a lot of patients, yes. And when it's diagnosed, they can still live with it for years.
Okay.
Now, not every patient will live many years, but some patients will live much longer than few years, and some patients may even not die of the neuroendocrine tumor.
Okay.
So that's the thing about the neuroendocrine tumors. Patients have to be counseled very well about what are the chances of them living long, because a lot of times has it's not really very well described to patients. And sometimes it's the other way around. Sometimes patients can have the aggressive form of the neuroendocrine tumor. However, they've been told that they can live very long with it. So it goes both ways. But most patients live long with the neuroendocrine tumors. In fact, I tell patients, if you want to choose a cancer, this is one of the cancers you want to choose.
Are there biomarkers associated with it?
So neuroendocrine tumors are diagnosed, and most of the time they're diagnosed as a advanced disease. Advanced disease doesn't mean that someone is like having advanced, let's say, lung cancer or breast cancer or colon cancer. These tumors, by and large, not all of them, even when they're advanced metastatic, spread to other organs, they still can behave in a very slowly progressing or growing fashion. So, in terms of biomarkers, there are biomarkers in this disease. And before I go to the biomarkers, I really want to explain one thing. So, neuroendocrine tumors also can be called functional or non functional. So, let me give you the distinction. Functional tumors are the ones that produce hormones. So sometimes patients get confused by saying, "Oh, this is a hormonal disease?" It's not a hormonal disease. It's not a disease caused by hormonal imbalance like we see sometimes, or cancers that are fed by the hormones in the body. So, like breast cancer is fed by estrogens, prostate cancer is fed by testosterone. This is not the case. However, these tumors can produce hormones, and these hormones can have a variety of effects on the body. I just want to give an example. The most common one people know about is called the carcinoid syndrome, where patients can get diarrhea, flushing, wheezing, palpitations. The
Okay.
majority of the patients really do not have the carcinoid syndrome. There are other syndromes that happen, for example, in patients who have pancreatic neuroendocrine tumors. And that could include, for example, low blood sugar from overproduction of insulin by the tumor, or the other way around, elevated blood sugar because they produce another hormone called glucagon, and so forth. So there are two types of neuroendocrine tumors. Another distinction, apart from the site where they can start and their aggressiveness, which I'm going to come to it, there's also the functional versus non-functional. So nowadays, carcinoid syndrome is seen again not in the minority of the patients, but it's something where it's very important for people to recognize. And the reason is that sometimes patients are going to the primary care doctor and they have symptoms, and someone in the family or the patient checks on the internet, oh, maybe I have carcinoid syndrome. And then the doctor says, okay, maybe you have carcinoid syndrome. Let me check and do biomarkers. The one that commonly is used is something called chromogranin A. Chromogranin A. The problem is that the chromogranin A can also go up and benign conditions have nothing to do with cancer. Like if you take like a proton pump inhibitor, that can push it up. So
Oh,
these patients, those patients now live in a very stressful situation. Someone told them you probably have cancer. It's carcinoid tumor, carcinoid, and then they're going from one doctor to another. And I have a list of patients who have come to me as an oncologist now. They come to the cancer doctor, and I say, like, you don't have it. We can do tests on you, but you don't have the disease. So that's something educational because so don't use the biomarker to diagnose the cancer or any cancer actually.
so your key point there would be, as a from a referral physician standpoint, not to utilize that biomarker. correct?
unless you have to really make what we call a tissue diagnosis.
Okay.
You know what a tissue
Yeah. Yeah.
you see something,
Microbiome.
biopsy it. Yeah, by labeling someone having a carcinoid tumor because they have an elevated biomarker, in this case mRNA, is wrong. You're really, in fact, disadvantaging the patient because the patient will go through probably a lot of testing, which uncomfortable, stressful, and costly. Without so first you have to see whether they really have a tumor somewhere. That's the most important thing. We talked about it can happen anywhere in the body, and again, our focus today on the gastrointestinal tract and the lungs and other parts. It can happen in the brain, pituitary, and in other endocrine organs. But one of the things that I mentioned was when it comes to the gastrointestinal tract neuroendocrine tumors, most of the time we diagnose them at a metastatic state. And the reason for that is, as you mentioned, they don't have symptoms. Now, sometimes when they have the functional tumors, like the carcinoid syndrome we talked about, or the other ones that cause like hyperglycemia, high sugar, low sugar, they're diagnosed. But even then, most of the time, they're in a advanced stage in terms of the metastases. And again, I have to say it again that metastases do not mean that patients are not going to survive long. I think that's something which has to be very well emphasized. Some may not, but a lot of patients can live years with this disease. So what does really determine how people's cancer is going to behave? One thing we use is something called the grading system. So we have tumors that we call them well differentiated grade 1, tumors we call them well differentiated grade 2, tumors we call them well differentiated grade 3, and then we have tumors we call them poorly differentiated. And most of the patients I see are either grade 1 or 2, luckily. But we see also patients who have grade 3 and patients who are poorly differentiated.
Do you see the patients more grade 1
And 2.
because they are referred earlier?
Well, no, because again, there's no referral earlier. All are grade 1 and 2 because they don't have symptoms usually, except if they have carcinoid syndrome. But someone does a scan for something else and they find something. And sometimes they are diagnosed because sitting, for example, in the stomach, in the intestine, and in fact in the terminal in ileum we call it, it can cause bowel obstruction. That's how they're diagnosed.
And when you're talking about differentiated versus undifferentiated, we're talking about the cell.
Yeah, I'm coming to that. So basically, the well differentiated versus the poorly differentiated, it's done on a number of levels. One of them is looking at the microscope, under the microscope, and see what we call the degree of differentiation of the cells, which is their morphology and number of other things that define them as being well differentiated or poorly differentiated, and the different grades. But the other one, which is really most commonly used, is something called Ki-67. It's a percentage number. Ki-67 really looks at the proportion of cells that are actively dividing. So it's used not only in neuroendocrine tumors, but it's also used in other cancers. Ki-67, like even in breast cancer, if you see some of the literature that published, that you can see it mentioned for Ki-67. And the higher the Ki-67, the higher the grade of the tumor is. That's a general thing accepted. So, for example, in patients with neuroendocrine tumors, well differentiated, as I said, it can come in three different shades. Grade 1 or grade 1 will be the ones who have Ki-67 of less than 3%. Grade 2 will be 2 to 20%, and grade 3 will be over 20%. Now, poorly differentiated tumors are way above the 20% mark. They're more like over 50 or 60%. These are the ones that we look at them similar to small cell lung cancer, that kind of tumor. So again, so you can see that we have different grades, of the tumor, and grade has a major impact on the prognosis of the patient.
Okay.
So patients who are newly diagnosed, it's really very important for their for them to check on the pathology report and make sure there is a mention of the grade. Because sometimes in situations where places where the disease is not commonly seen and the experience, etc., I've seen every now and then people coming to me with a pathology report which may not include the grade of the tumor. So that's really very important. So why is the grade important? It's very important because it gives you an idea of the prognosis. Obviously, it's not black and white. Nothing is black and white, but it gives you a good idea of the prognosis. It also helps the treating team, medical oncologists, and others to decide on which treatment to start off with.
Okay.
So let me take you a bit further with this. So if you have someone who has grade 1 tumor, which at Ki-67 less than 3%, they're asymptomatic. It was just discovered by chance. Someone had a bit of abdominal discomfort. They did a scan and they found some lesions in the liver. So the liver, for completion, the liver is the commonest site where these cancers go to. And that's one of the ways that they're diagnosed because someone has a discomfort in the abdomen. They do a scan, they find liver lesions. And they do a biopsy, it turns out to be a neuroendocrine tumor. Or someone can be like myself, I have kidney stones. And every now and then I end up in the emergency room, get a scan done, right? And that scan may end up showing incidental finding in the liver as a metastasis. That's how I'm saying, oftentimes it's diagnosed at a more advanced stage. Advanced stage, I'm using the terminology advanced stage, not meaning that someone is diagnosed today and their life is very much threatened within the next 2 years.
Right.
Advanced stage as in it's spread to somewhere else. So that's really how we diagnose it. And so going back to my example, if you have someone who's like any age, I would say, and they have a diagnosis of grade 1 neuroendocrine tumor in the liver, it's metastasis to the liver, start in somewhere like in the intestine. Those patients we sometimes we always when I talk to them, not sometimes, always, if they're asymptomatic, I say, well, there's an option of no treatment, just watching you for a while. Because you can do that. You can do that if you got your diagnosis correctly and evaluation correctly.
Is watch and wait standard for these tumors?
So I'm trying to be very careful in what I say here. I say I give them as an option. I give them as an option because you have to really. Okay, so the patient says, "Okay, if I watch and wait, what happens next?" I say, "Well, you do a scan in 4 to 6 months, and that scan will give you an idea of the tempo of the disease. If you do a scan in 4 to 6 months and the tumor has only increased by 1 millimeter or no millimeter or 2 millimeters, still asymptomatic, well, we can sit on it. We can do that. But you have to explain all this to the patient. Unfortunately, because it's not a common disease, they really don't get a good, balanced, comprehensive explanation a lot of times. So they can start on some treatment where the patient may not be happy, they could have waited, or the other way around. They may not be given treatment, but not given the option of treatment.
Philip, as we have mentioned on previous episodes with you, John and I have had multiple discussions with regards to the importance of a multidisciplinary team. Is that also the case for during the diagnosis pathway of
So,
neuroendocrine tumors?
so that's a very good point. Again, not trying to brag about anything. Like within the state of Michigan, there's only one place that has a tumor board dedicated to neuroendocrine tumors.
Okay.
We have it. We do it every other week, so twice a month. And it's a very important question you're asking because the expertise of neuroendocrine tumor in a given state can be very patchy because these tumors are rare, not common. At the same time, they may gravitate more towards the major centers. So community hospitals, the experience can be really, really very little. I mean, I'm going to my clinic today this afternoon, and I'm doing only 3 hours, and I'm seeing 4 patients, and all of them are neuroendocrine tumors. 2 of them new patients to me. That happens maybe in 1 year in a doctor who's in the community, because they gravitate towards the major centers. So the same thing, like the tumor board may not be as experienced in terms of the different people who are on it. So the advice is always like there's no harm in patients seeking second opinion. I think that's the really where it comes down to.
So just to summarize where we are at the moment, grading was really important. How do patients ensure that their grading is done by the pathologist? Do they have to ask for it?
So the grading is done most of the time. However, the patient should have a look at the pathology report and make sure in the pathology report that was mentioned, basically. That's the key thing. Now, if if it's not mentioned, then they can discuss it with their own doctor and say, was it done? Wasn't it done? But again, if it's not done, they can go back and do it. It's not like it's an immunohistochemistry thing. It's a standard pathology thing. So
Okay.
sometimes it's not done. Now, why sometimes it's not done? Maybe, again, it can be experience, or sometimes when they were evaluating the pathology, they didn't think this patient might be having neuroendocrine tumor, although that's a very unlikely thing. But the bottom line is that patients can have a look at their pathology report, request a pathology. And nowadays, it's very easy to get all these things, even online, with patients having access to AMR. And then if it's not there, to just discuss with their doctor so that the doctor can request it. It's a doctor who's going to have to request it from the pathology department. It's simple. It's not really that complicated.
Right. Because I think also based on what you're saying, without the grading, A, it determines the prognosis, and then B, it also determines the sort of treatment that the patients have
Exactly.
to access, right?
And
That's very correct. So it's very important to have that in place. Yes.
and you were mentioning that it's the disease in the United States. The way it's assessed is different from state to state, and it can be patchy. Are there guidelines that are coming out? I noticed that at ASCO this year, they set a new set of
Well,
guidelines
yeah.
for.
I mean, there are guidelines. There always one can refer to. So it's not so much, I would say, varies from state to state. It varies more like hospitals that have high volume, like teaching hospitals, large centers versus small community practices. So that's really where the variation is. And again, the expertise, the multidisciplinary expertise is variable. In major centers, as I gave you an example, our place, we have a tumor board dedicated to neuroendocrine. Well, it's difficult to do that in a community center because maybe they don't have enough, probably they don't have enough patients for sure, and they don't have enough people who are focused on neuroendocrine tumors, or sometimes they don't. Going back to the guidelines, as you know, John, NCCN guidelines, which you are very familiar with, so that's
Mm.
one resource. There are guidelines in it, and you're right. The ASCO guidelines, European guidelines, the guidelines are all over the place. So it's not really that difficult to access guidelines. But again, it's having people who have the interest in the disease, who follow the latest in the disease and what is updated in the guidelines, etc. That's really what people need to be exposed to. And again, I want to stress the idea that this is a particular disease where I would very much strongly recommend people seek a second opinion if they feel that within their existing care there isn't a deep focus into it. And I have to tell you that doctors, especially medical oncologists, are very honest about these things. I mean, they will tell the patient how experienced they are.
Right.
It comes down to the volume of the patients they see with neuroendocrine tumor. But as a general rule, community hospitals, community physicians see much less than people in the bigger teaching hospitals or the cancer centers or large healthcare based organizations where the volume is much higher. It comes down to also volume.
At the beginning of this talk, you mentioned that there is risk in patients. For the high risk patient now that comes in, what's the pathway of treatment? Do they go to surgery first?
This is a cancer where it's no different than other cancers. If the disease is localized, Like, let's say it's localized in the one part of the intestine, which is terminal ileum or rectum, or if it's localized, for example, in the pancreas, localized disease. You do tests and you don't find anything elsewhere. Then those patients certainly we go for surgery, like you treat any other cancer that's localized to an organ.
Okay.
The catch here is that if you have someone, for example, with pancreas cancer and they have liver metastases or something like that, or you have colon cancer with liver metastases, or gastric cancer with liver metastases, or rectal cancer with liver metastases. In those patients, people don't reflexively think about surgery. In when I'm talking about the regular adenocarcinomas, because you always think about chemotherapy being your major player and surgery as a important but not necessarily something you do upfront or you think about it upfront because you want to treat the systemic disease. Now, with neuroendocrine tumors, especially with the lower grades, like grade 1 and 2, let's say, surgery, even if someone has metastatic disease, people can have surgery. And we call it debulking surgery. Because patients with this disease, they live long, many years, then you can justify trying that part of the tumor out, even if you're not going to clear everything, because that will help the patient to not have symptoms as the tumor grows further. I'm not sure if I'm making it clear, but here there's an issue of debulking that we don't think of. So when people talk about like gastric cancer or pancreas cancer, no one's going to do debulking because the whole thing is that it doesn't make sense if you leave something behind. Leaving something
Do,
behind in this disease is allowed.
when you're debulking, do you use neoadjuvant treatment to debulk along with the surgery?
Well, that's another difference because the treatments we have, they don't go up to the level of a lot of shrinkage of the tumor. So for that reason, neoadjuvant treatment sometimes is considered, but it's not a mandatory like we do, for example, debulking for, trying to treat metastases, not debulking, in patients, let's say, colorectal cancer with liver metastases. So, so this is a very important point because that takes us to back to the question of expertise. So you need to have expert surgeons who can handle this debulking and also expert surgeons who feel confident enough that they agree and want to go in. And this is what happens when patients sometimes are diagnosed. Someone might come to me with a bulky mass in the abdomen, mesenteric mass, and the doctors say, okay, you have advanced disease. We can't do anything. Let's try some systemic treatment. They come to us and we say, well, that mass, if you're going to live the mass for a number of years, with time, it can block your intestine. So we go back and remove that mass. Even if we can't remove the entirety of the mass, we remove as much as we can or all of it to avoid the patient down the road having a Friday afternoon bowel obstruction and being treated by a general surgeon who doesn't have experience.
Okay.
But this is a critical evaluation of the patient. This is what I'm talking about. Tumor board, second opinion.
I guess the question I have for you also is part of the debulking strategy. Is there a size threshold that one, like a surgeon would think about, or does that even come into consideration?
So it depends. I mean, certainly within the abdominal cavity, like the intestine, blood vessels, etc., it becomes an issue not so much size, but how much can I remove without sacrificing the blood vessels and things like that. The liver, where a lot of the debulking happens, we say that if you keep 30% of the liver, able to keep 30% of healthy liver, do as much as you can.
Okay.
So remove as much as you can, as long as you leave like 30% of the liver, normal liver.
You mentioned that the liver is primarily where the metastases go. Is there, for the listeners, is there a reason for that?
There's no good reason except to say that the way the blood drains out of the gastrointestinal tract goes a lot to the liver. I think that could be, But also we see liver metastases coming from lung carcinoid or neuroendocrine tumors. So that's also, we see that.
I don't know whether you're gonna be talking about radioligand therapy and how that plays a role within the treatment pathway.
Sure, yeah. So let me take something off the table so that we can focus on the other one. So the poorly differentiated tumors, we talked about it being like small cell lung cancer, right?
Mhm.
So these tumors, we really treat them like with chemotherapy, like we're treating the lung cancer. So no radioligand therapy, nothing. So take it out. So with the other tumors that are well differentiated, grade 1, grade 2, or grade 3, one of the fundamental things about this type of cancer is that tumor cells have something called somatostatin receptors. Somatostatin receptors. In fact, the expression of the receptor is also part of the diagnostic thing they do in chemistry when they diagnose the thing pathologically. So the somatostatin receptors, think of it like you're thinking of estrogen receptor.
Okay.
So with the estrogen receptor, you have strategies that you're targeting the estrogen receptor, all the drugs, tamoxifen, letrozole, etc. In patients who have this type of cancer, the less differentiated, like grade 3, will have less of the receptor than grade 2. Grade 2 will have less of the receptor than grade 1. So when you have grade 1 tumors and grade 2 tumors, a lot of patients, we don't start with any chemotherapy or radioligand therapy, and we start them with, we call them somatostatin analogs. So we have lanreotide and long-acting octreotide, for example. And the whole idea is that they target that receptor to slow down the tumor. And back to the question, like John asked, do you give neoadjuvant treatment? These treatments do not shrink the tumor down. They keep the tumor steady for as long as possible. Now, patients who don't respond to the somatostatin receptor analogs, you go to the second line treatment. And in the older days, we used drugs like everolimus, or there's also sunitinib in patients who have neuroendocrine tumors of the pancreas. Now we have cabozantinib. So you have 3 oral agents that you can use depending on site the tumor is. However, in 2018, January 2018, the FDA in the United States approved the radioligand therapy, lutetium-177.
Okay.
And that treatment became available to us, also known as Lutathera. So PRRT or radioligand therapy. So PRRT or radioligand therapy in this disease, if you remember what I told you just a couple of minutes ago, you have this somatostatin receptor.
Yeah.
So the somatostatin receptor is a receptor, and a receptor is like this, and something comes and sits on it, and we call it a ligand.
Okay.
So what you do is you create a molecule which can come and fit on the receptor, and that molecule is linked to a toxic payload.
Like an ADC?
A toxic payload, which is similar in some ways to ADC. And that toxic payload, in this case, we're talking about Lutathera, is lutetium-177.
Okay.
So what happens is that sticks on the cell, kills the cell. That's really what it is. Now, the good thing about the Lutathera is that it became approved by the FDA, as I mentioned. Before that, we were sending patients to Europe to have it done. Europe started it way before the United States. United States were waiting for a phase 3 trial. It happened, results presented, published, etc., and was approved. One thing which I really want to mention to you, which is basically what it really means now, is that there are a number of companies that are producing other types of radioactive material, and patients have to be aware of clinical trials that are happening in the United States. Especially if they fail, their disease doesn't respond well to the Lutathera, there are other
Mm.
compounds that are currently being tested. So it's very important for patients to seek advice on clinical trials in this disease, especially if they're had the Lutathera and is not working or didn't work or worked for a while, it stopped working. So there are clinical trials that are currently ongoing.
So this really reinforces the larger clinic and the multidisciplinary teams in those hospitals like yours, Philip, that they should be going to so they get access to the trial.
Again, this is very important to have a second opinion. Now, having a second opinion means that the person who's providing second opinion can work with the primary oncologist. We're not asking the patient to necessarily to be treated by a large cancer center, but a plan of treatment can be discussed with the primary oncologist. And I think that will be a very good thing for patients. The other thing is that the thing I mentioned to you about having a surgical opinion sometimes is very important. Surgeon who really does this kind of surgery. And there are a number of surgeons around the country who really are very good in managing advanced disease in terms of bulk or volume to trying to reduce it. I have a patient, a 40-year-old patient who's going to a surgeon, not even with us, she's going to a surgeon in a different state to have an operation where she has a large liver metastases, but she's young and she wants to go through. Now, sometimes one can take it to the extremes because there's also the possibility, and I want to say possibility, of even liver transplant in some patients. Uh,
Okay.
so that's another possibility, but it's a very, very highly selected group of patients who may benefit from a liver transplant. But I don't want people to think about it this time because it's really highly selective. It, and I say rarely happens, but it's a possibility. Really, it comes down to the fact that people have to seek opinion because there are different things that one can do depending on the situation. It's one of those cancers where not every two patients are the same. Now, when I treat the patients, manage the patients, I also very much take into account their what they like to see being done, giving them the options, their psychosocial situation, their family support, age, profession, everything. You have to really factor everything into it. This is not a cancer where you tell patients, okay, I think I suggest you give up work and focus on your disease. We don't do that most of the time. Most of the time, we don't do that because patients have to live with it. And that's the goal of the treatment is to live with it. This is type of cancer where we'd like patients to live with it. We don't want them to be really completely giving up everything and just focusing on chemotherapy, hospital visits, and all that.
Is there genetic and molecular testing that patients can have, access to in terms of personalized treatment for neuroendocrine tumors?
So basically, I'm sure you've heard about personalized treatment in terms of next generation sequencing, and you mentioned initially biomarkers. By and large, they're very sparse, and by and large, they don't help the treatment. We do them because sometimes we end up with something, but it's very rare to see something that we, and even the genetic component, whether they have a risk to the rest of the family, it's very rare that we see patients who have, and I do all these things routinely on my patients, by the way, and it's rare for me to see something that throws me into, oh wow, I can change the treatment or the target agent. That has really very little application in a disease like this. I can also say that immunotherapy, which is very
Mhm.
much popular in other cancers, immunotherapy, I would reserve it to patients who have poorly differentiated. Again, we treat them like we treat Lyme cancer small cell. So that's it's not used in in the majority of the patients. We don't use immunotherapy. We don't think it works well. Now, the spectrum of treatments that we didn't discuss in detail, I just want to add a few things, and just adding to the multidisciplinary equation or the argument. There are
Yeah.
also patients who we treat with what we call, or are treated by intervention radiologists. So what do they do? If there are one or two, three lesions in the liver, they can ablate. They can put something ablate by radiofrequency ablation, cryoablation, microablation. There are also sometimes patients who have disease in one corner of the liver. They can be treated by liver artery directed therapy, like Y90, which is going through the groin and going up to the liver. So these are cool things that people do, the intervention radiologists. So we have them on the table when we discuss patients for sure, for that reason.
And, we haven't talked about numbers, which is surprising because John and I always like to talk about numbers when it comes to survival. Can you comment on, what kind of survival numbers we're looking at in terms of your early well-differentiated versus later on the poorly differentiated and the treatments accordingly?
So I'm one of the doctors where I'm going to respond to your question, but I just want to make a statement about myself. I'm one of the doctors who consistently have not talked to patients about survival in terms of numbers or years.
Okay.
I don't do that for a variety of reasons. One of them is that I've seen so many patients I've seen all over the place. I've seen a big range of survival for a given situation, for a given stage of a disease. So I don't really go into much into survival in terms of numbers. The second thing is that what really determines survival when a patient comes to see the doctor for the first time is how that disease changes over the next 6 months. The doctor will have a much better idea of survival. But having said that, in patients, for example, who come again, let me handle the poorly differentiated. In patients with poorly differentiated cancers, their survival is limited. It's like, as I said, like we see in small cell lung cancer, very aggressive disease, survival is barely a year or so. However, on the other end of the spectrum, we have the well differentiated grade 1. Those patients can live in excess of 10, even 15 years. They can do that on average. They can do that. But again, do I label every patient that's going to do that? Of course not. But depends on patient's volume of the disease and some other factors. So these are the ends of the spectrum. In patients who have grade 2, their survival is shorter. But again, it's also measured in a good number of years. Sorry.
Okay.
Patients with grade 3 tumors, it's shorter. Again, it probably again goes into 2-3 years on average. Average is not that short. It's not like the poorly differentiated cancers tumors.
Okay.
And by the way, the poorly differentiated neuroendocrine tumors, we call them neuroendocrine cancers.
Okay.
We don't call them neuroendocrine tumors. We call them neuroendocrine cancers. And another thing which I should have mentioned earlier, the older way of referring to the well-differentiated tumors was carcinoid tumors. So there's carcinoid syndrome, which is the syndrome of symptoms, but the carcinoid syndrome was typically the ones who are low-grade tumors. So collectively, if you think about it, you will have patients who live with it and they can die with it, not necessarily of it. And in those patients, you have to be careful not to disrupt their life too much by treatments and testing and all that. And I have patients who, after a while, I said, you know what, let's stop treatment. And we're giving them monthly injections of lanreotide or octreotide. And you say, let's stop it. I mean, they get frightened. I said, no, I'm comfortable doing that. And I think that's something which is worth considering in patients who are really on the other end of the spectrum, which is almost behaving like benign disease. It's not benign, but it's behaving like benign disease. So survival is, generally speaking, survival is a bit worse in patients who have pancreatic neuroendocrine tumors compared to the small bowel. Stage 4, stage 4 stage, grade 4 grade, pancreatic neuroendocrine tumors do worse than the patients who have the small bowel tumors. Why? Biologically, they're a bit different, but that's a reality. The good thing about the pancreatic neuroendocrine tumors is that they have more treatment options, systemic drug treatment options, and also they respond better to treatment. So that's the one way or another. Yeah.
Just talking on treatment, I noticed that at ASCO, I couldn't get to the presentation. There was the StarterNet trial, which is lanreotide plus everolimus versus everolimus, and patients were actually in that study because the PFS is really long.
Those are well differentiated tumors, obviously, like the grade
Yeah.
1 and 2. Yeah. Yeah. Those are the patients who you treat them with lanreotide or octreotide. The grade 3 tumors, we tend to oftentimes start with chemotherapy. And the chemotherapy used more often is a combination of capecitabine, a drug used to be called Xeloda, and a drug called temozolomide. It's an oral regimen. Yeah.
We haven't. So, Philip, there's two things I wanted to ask you. One is side effects from all these drugs. If you could quickly comment on them, because I know targeted therapies have very different side effects than immunotherapy than it would with the
So,
Okay.
so basically, the side effects of the treatment. I'm going to start with the mildest treatment would be the monthly injections of octreotide or lanreotide.
Okay.
And the side effects are really very minimal. One side effect is that it can get complications of cholecystitis because it can affect the function of the gallbladder. However, sometimes we see a symptom of diarrhea which follows the injection. Like they have injection today, they have diarrhea for a few days after the injection, and then it disappears. Generally speaking, very well tolerated. Well, there's discomfort because they get it intramuscularly. That's a discomfort, but otherwise very well tolerated. Then you move up to like drugs like everolimus. You have more side effects, fatigue,
Mm.
maybe diarrhea. And then you move on to drugs like cabozantinib, again, skin rash, maybe liver dysfunction, sunitinib, liver dysfunction, skin rash. And then you come to the Lutathera, which we talked about, the radioligand treatment. That one is an interesting one. It's given IV, intravenously. It's given once every 2 months intravenously. They get only 4 treatments, and that's it. And the treatment takes maybe half a day, outpatient treatment, and they're done. Side effects are a bit similar to chemotherapy because it can affect the blood counts, white cells, platelets, hemoglobin, remote possibility affecting the kidney function, remote. And there's a very rare 1 to 2% possibility of it causing leukemia, acute leukemia, but
Mm.
generally very well tolerated. And then if you move on to capecitabine and temozolomide combination, that one will give you the side effects that we know of chemotherapy. Again, fatigue, hand foot rash, effect on the blood count. These are the major skin rash. These are the major side effects that you can get from it. Generally speaking, the treatments that we give, systemic treatments, are relatively well tolerated by patients. Obviously, you have to know how to adjust the doses and look for things, but generally speaking, but the key thing is, again, that there are also clinical trials around, and patients have to be familiar with them. Again, in a disease that they can live number of years with it, it's good opportunity for them to really be on a clinical trial to see what is out there. Certainly, the future is for different types of radioligand therapies. You're absolutely right. That's something which is coming up, and there are a number of studies in that respect. So I encourage patients to look into that, seek opinion, and as you know, they can also check the clinicaltrials.gov website because that also can be informative.
And I would imagine, Philip, that you're involved in a lot of those studies.
Well, I do, especially with my SWOG, work I do at SWOG.
So would you just like to talk about your work at SWOG for a second? Because you've only got 10 minutes to go.
So the Southwest Oncology Group, or SWOG, is a national cooperative group which is under the auspices of the NCI CTEP. It's one of the few we have less than a handful of them. So as you know, there's Alliance, there is NRG, there is ECOG, and within SWOG there are scientific committees according to disease sites. Obviously, it's all cancer related. So there's the gastrointestinal committee, there's the thoracic or lung, there is the genitourinary, etc. So I chair the committee which involves with gastrointestinal cancers. So our role is collectively, our committee is to really do studies, clinical trials that are applied at the national level, and cooperating with the other groups to really disseminate throughout the United States. And we're looking at ways to try to improve delivery of chemotherapy, to try and find better chemotherapy or other agents, especially in the era of the targeted therapies, getting new drugs into the mix. And a lot of studies now, which people are thinking of with the existing treatments, making it easier on the patients in terms of the treatment, how it's affecting patients with the side effects, etc. So the trials are done, as I said, at the national level. They have a lot of credibility. They, most of the hospitals do open these clinical trials, and that's part of what we do. So it's a very thing, and also it's a kind of a system where it has a pipeline of younger investigators that we train to go through the system. So it works very well. We work closely with patient advocates also.
Okay.
So that helps us in the design of the trials. So it's a bit of a different angle from the clinical trials that I've done and designed by the pharmaceutical industry, but complementary.
And congratulations for all the work that you've done in SWOG over the years. It's been heroic effort, and the work that you've brought to patients is just super. So, Phillip, you've been ahead of that GI group for a long, long time. So thank you. The last question I have is, if you had to summarize this talk into 3 bullets, what would you say to the patients out there about neuroendocrine cancer and neuroendocrine disorder?
Well, that's a tough one. I mean, one of them is, I'm going to say it. One of them is that when you're diagnosed with this disease, you really are required to know everything as much as possible about the disease. You need to be well informed about the disease because this is a disease that, by and large, you're going to live with it for a long time, most of the time. And the good thing about it is that it's not as aggressive as we see in many other cancers. However, that doesn't apply to everybody, as I said before. So you need to know a lot of stuff about the disease and the management of the disease, the treatment of the disease, prognosis, obviously, because you can plan your life accordingly. It's not something which is to be seen as a definite death sentence or something like that. And the second point to make is that, unlike many years ago, the current atmosphere and the strategy is to find treatments for this disease. For a long time, people kind of ignored this disease. There wasn't enough emphasis, there wasn't enough investment in this disease. But now there's a lot of work being done. So it's very encouraging future for you because between the like the radioligand treatment that we talked about and other treatments, there's a lot of work being done. So it's very encouraging. And the final point is, with all of the above, you really have to ensure that you're being treated by doctors that are well informed, whether they are in the community or not, but well informed as in they can work with other doctors who have a lot of experience. So getting a second opinion or asking your doctor to make sure that they talk to another doctor who has a lot of experience. And in all states we live, there are centers centers that are very well experienced. So I think the issue of the second opinion is one of the most important things in this disease because of 2 reasons. One is you don't want to be overtreated,
Right.
almost at the same time, you don't want to be undertreated. So it goes both ways. You can easily be overtreated and you can easily be undertreated in this disease. So undertreated example is that if there's a tumor that's sitting there and can be taken out, why leave it there? Take it out, even if it's big, remove part of it and gives you a lot of relief. That's under treatment if you don't get that. Over treatment, if you have a very low grade, slowly growing tumor and you're just getting those poisons, the drug, the things, why get them? Not to mention the discomfort, the cost, and time you spend on that. So,
Thank
Yeah.
you, Phillip.
Thank you, Philip. This
So,
was fantastic.
did we cover everything?
I think we
yeah, I
did.
think so, definitely.
Well,
Just also, before I close out, congratulations on your daughter going into med.
Yes.
yeah. Thank you both of you for having me. I really enjoy it. And if there are any questions that come up afterwards, I'll be happy to do anything necessary to clarify things. But this is something which I really feel strongly about people to know about because it's a very loose kind of topic in a way, made loose for a good reason also because it's not something which threatens the life of the patients most of the time, like immediately or in the near intermediate future. So it means that they live with it. It means that we have to make sure that they are not only survivors, but they have good quality of life, or they maintain the quality of life.
Right. Yeah.
A better expression. Yeah.
Thank you, Philip.
Thank you. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.